Hi, Award episode. Today, I'm excited to present our P.A.D. Humanitarian of the Year award to an incredible doctor who truly embodies what this recognition is all about. Before I introduce him, I want to share a quick story of me personally. There was a patient with advanced peripheral artery disease. That's the PAD, or poor circulation in the legs. It's a disease more prevalent and deadlier than prostate cancer, colon cancer, and breast cancer combined. Well, this patient, their doctor reached out to our Leg Saver hotline at the Global PAD Association when his patient was in a really tough spot. She had moved clear across the country and wasn't sure if her insurance had transferred yet from Pennsylvania to California. And yet she was in the most advanced stage of PAD known as critical limb threatening ischemia, or CLTI situation. His response to me, we will worry about insurance later. The most important thing right now is we need to save her leg. And that is exactly what he did. He saved her leg without hesitation. That's the kind of person Dr. Nick Patel is. Dr. Patel runs AVA Vascular in Murietta, California. That's in Southern California. And as a vascular and interventional radiologist, a PAD specialist, he's not just technically brilliant. He is always available, not only to his own patients, but to our entire global PAD Association community, answering questions in our forums and making time even for our patients on weekends. So many patients tell us the same thing after seeing him. I just felt hope again. And that means so much to these patients. When you've been told amputation is your only option and someone like Dr. Patel steps in and changes that outcome, it's not only limb saving, it's life changing. So it is my absolute pleasure to present this year's PAD Humanitarian of the Year award to Dr. Nick Patel. Congratulations, Dr. Patel. So well deserved. We appreciate you
So much, Kim, and to your organization. It really means a lot to me and my family and my patients. More. So thank you for this award. I appreciate that.
I mean, isn't that such a humanitarian beyond the call of duty, for your patients? And you, can I do even more, which is amazing, which, you were drawn to specialize in vascular medicine in the first place. And what really continues to motivate your love and PAD patients?
Um, was a thing that I wanted to do when I was about 14 years old, when I went to a hospital for a sort of observership, and I saw the radiologist in the office picking up his dictaphone and dictating a X-ray that was on his view box those days. And I'm like, this is a physician who's doing this, creating a patient outcome. So that really impressed me as radiology, unlike impact, the change that I saw something on an X-ray, and if I could go change that and treat that, and that's where interventional radiology came in to help that patient, not just help to diagnose, but also treat and improve the quality of life or care. Um, and vascular medicine is something that gives you immediate gratification. You fix their outflow, and as soon as they're getting off the bed or procedure table, they can feel a difference. And that is the most gratifying thing I feel in a vascular medicine world. You see the impact immediately.
Care above insurance concerns. One I mentioned right in the introduction. Could you share your philosophy on healthcare accessibility, particularly for those facing limb threat, more and more issues with insurance, especially Medicare Advantage plans, where pre-authorizations are delaying and even leading to denials in care for. I'm not talking about early stage intermittent claudication patients. I'm talking about advanced stage, limb is on the line, and patients are being told, wait another couple weeks. We need to go over you. I just don't think you need this particular procedure.
Right. No, that's this is the who had expressed to me that um, medicine. Um, First of all, it's a very demanding job. It also is a very rewarding job. But you will come across people who really need your help. At the time when they need help, not at the time when it's convenient for you. So you need to step up to that game. What he meant was that, you will come across people, patients, uh, who may not have the financial resources to afford the care that you want to provide. That's a moment if you step in, that is what's going to carry the legacy or help those patients remember you. Um, and that was a perfect situation for me, and many other situations that come across. You know, um, I've gone to, when I finished my fellowship and became an attending, I had a nonprofit organization in India, and I would go there every year and train other physicians to do vascular work. This is about 2004, 2005. And what came to my thought was that if I can travel all the way to India to do charity work, if I have a patient knocking on my door for that same work, why would I deny that? It's
Yeah.
doing charity right here in my doorstep, in my office. So that is my philosophy on that. Um, and America is a great country. You have a lot of resources. We have technology that's available to, have great outcomes for these patients. And I want to also give credit to the industry because it's not only me, but the industry also has backed me up when I've done these procedures. They'll say, don't worry about using a laser or atherectomy. We'll cover that for you. Just focus on the patient for supporting me to do the work that I'm doing, especially for the patients who really need this kind of service. Um, and there is, every one patient that I've treated free patients with insurance. So I think you have to keep that mindset open, that it'll come. When you do good work, people will find a way to get to your door and ask for your help. So uh, I think the last thing you want to deny care for somebody who really needs it just because of a financial reason.
Yeah, I just remember that one situation, and we had a doctor in Pennsylvania who said, I was ready to help this patient. This was like on a Friday, Monday or Tuesday, open up the arteries and hopefully try to heal a wound that was infected. And the family member said, oh my gosh, I can't take off more for work. I am going to get this family member on a plane and bring them out to California. And suddenly Monday and Tuesday rolls around. So they moved them out to California. And so this doctor calls me on the Leg Saver hotline and says, the patient's still infected. They need help immediately. And we need to get her on antibiotics, et cetera, et cetera. So I was able to get on the phone with the patient's family and get them in the emergency room, at least to get the patient on antibiotics. And meantime, this is like fast forward Friday night is when, et cetera, et cetera. And I think I called your number on that Friday night. And I talked to your wife who runs the office. And she put me on the phone with you, and you were like, about her insurance, just bring her in. And the insurance dust settled. She's still coming back and seeing you, and she's doing great, I hear, to this day.
Absolutely. And I want to tell you an interesting story about that patient. I don't know if I've told you this before. So the first time her daughter, she had taken all that effort to, travel to the East Coast, bring her mother over to the West
Yeah.
Coast. And then my office is also at least about an hour and a half, 2 hour drive from where she lives. So she came over here, and her mother is Spanish spoken, so she doesn't speak much English. But she came into my office, and we got her ready in her gown and everything, and she started crying. Um, And I was wondering what happened. And I spoke to that. Her mother felt like she's seen this place, my office, in her dreams. She had seen this scenario playing in her mind, in her dream, that this is the place. So she was very familiar with this, with my office, but she's never been to my office, and I've never met the patient. So this is something that we don't have reasons how we can explain these situations, but there's so many situations these patients are going through in their background which we don't know, and making it hard for them to get access to Medicare.
Yeah.
It's even just another obstacle. So, in my mind, I want to make them feel that, hey, I'm here for you. I mean, a lot of
Yeah.
times the recovery is patient's shoulder say, I'm going to take care of you. And that's all they need to hear. Uh, I know the case is complex or whatever it is, and maybe I might giving that hope to the patient, saying, I'm going to take that, where that's that somebody's there with me in this fight, and I'm not alone. So I think that psychological impact plays a major role in recovery, in this critical patients, who are on deck for amputation, or they're in severe pain at nighttime. They can't. I will take care of you. I think makes a big difference.
I agree. And I remember when you spontaneously jumped on our Lifesaver hotline on a Saturday to help a patient who had a genicular artery embolization for her knee arthritis. And she was worried when her doctors were not responding over the weekend about certain symptoms. What did you find so rewarding about that particular interaction, and what motivates you to be available for you? I know that you and your wife ends just in case they need you. Just before this interview started, you were excited about moving closer to your office so that you could be there in a moment's notice, even on a weekend, to open the office in case a patient needed care.
Um, I think my situation is a little different because I'm in a private practice. I own my own practice, so it gives me the flexibility to be, around whenever I want. Cell phone numbers to every patient of mine. It's on my business card. Whatever. The one thing the reason I do that is because when patients fall sick, they don't decide to fall sick from Monday to Friday. They can fall sick on a Saturday or Sunday, and I think having that continuity of care, and the ER physician is kind of lost because he can't reach anybody on a weekend. Done with this patient, especially our CLI patients, with wounds, they might even end up on amputation. Monday comes around, so it's important to have that communication, and uh, you know, taking care of these patients on a weekend, to say, hey, I've treated this patients, I've treated such and such vessels, and these are the other vessels that I still need to treat. So don't amputate this patient yet. They need one more chance. Uh, so having that communication, that resource is very important. So I give my number to the patients, and I tell them that if you ever don't get hold of me, or if you end up in the ER, give this number to the physician who's taking care of you. So at least I can tell them what I've done. And, um, if there's another opportunity or another option that's available, we can discuss
Yeah.
that with the physician. So they're not putting through this, you know, process of, doing everything again, working imaging and all this. It just waste of resources, as well as the anxiety on the patient that brings
Yeah.
doing all these tests again and to do. But like it's practice where I can do that because I make the call how I want to run my practice. So
Yeah. Another case that just came to mind. We have quite a few cases, but this one, as you were just talking, this one also warms my heart. But my dad and I were down in Carlsbad, and we were having lunch with a former colleague of his from very, very long ago. And he was mentioning his wife during the lunch after hearing what I do for a living with the Global P.A.D. Association. And even though I work with arteries, he said, a lot of people don't know the difference between arteries and veins. And some doctors talk, as if they're synonymous, but arteries run south, veins run north, carrying the the blood back to the heart to get more oxygen, more nutrients to be delivered through the arteries, right? So the patient had had a DVT, I believe it was really concerned, had just been really, weeks down the road, and she was still really worried and didn't have a chance to have a grander conversation about the risk factors and such. And I called you up right then and there while we were at lunch, or I texted you. And I said, this is, another facilities patient. Would you mind just reviewing the case, doing some additional follow-up testing? And she was great. But to ease that anxiety for patients, you mentioned, just a few moments ago that patients, they don't choose to fall ill. They don't, choose the timing to fall ill. And it's a 24/7 thing that plagues you both physically and psychologically there, and be readily available when these patients have questions. And the fact that you're willing to give your cell phone number and you're willing to be open to be there for these patients wherever they are, it is such a great quality and speaks volumes for your character.
Thank you, and that's the challenge for a lot of these patients is it's a follow-up care or continuity of care, and I think that's one of the things that we can improve every weekend or every night. But when people call me, that means, especially if they call you after hours or a weekend, that means they need something that needs addressed right away and can't wait. So I've not had patient call me saying to chat with me or something that was not emergent or urgent on a after hours or weekend. So I think my patients are okay too when I talk to them.
Yeah. Yeah, and we have Douglas who's tuning in. This, especially in the beginning, and so many of your patients just mentioned about regaining hope after working with you. You touched on that psychological aspect of things. How important is the psychological aspect of treatment? Threatening ischemia as they do with P.A.D, and they go online and they think they're going to be dead in 5 years because that is the number one search optimized article that they find when they seek P.A.D is you have P.A.D, you get diagnosed with P.A.D.
Absolutely, and that reminds me of the movie The Shawshank Redemption. About uh, where hope is a good thing and probably one of the best things, and good things never die. So I think hope plays a major role in recovery of these patients. And if you are the physician taking care of them, for a patient, a physician is something that they respect. They take their opinions and the advice seriously. And if you are in that position, then why would you not take the opportunity to not only treat them, but they need to motivate them or stimulate them to say that, hey, look, this is not the end of the road. You have chances. We have many chances,
Yep.
to get you feel better. So don't give up, and I'm going to stand by you. So I think a lot of the psychological impacts are a factor in recovering for these patients. I had a
And
I'm sorry, I had a patient who I don't know if you can. I have a picture of his foot here, and I don't know if you can see it, but this is what his foot looked like when he came to me.
oh yeah, oh yeah, oh wow.
The entire foot is gone. A young guy, 38-year-old with diabetes, admitted in the hospital for infection, and they said only option you have is an amputation. He refused an amputation. He ended up going to a nursing home. There's a physician who refers patients to us that rounds on this nurse. First time he was all depressed, he's like giving up hope. Um, just looking at his foot. When I saw his foot, I'm like, how can I help this patient? As I said, let me just do an angiogram, see what it looks like. And most of his disease was more tibial and pedal, and that too only two blood vessels. So I was able to open that up. I gave him positive motivation, and I said we got to work together. This is going to take some time, but we got the first step in place. Get the antibiotics, get the wound care, and all that. And 9 months later, this is what it looked like. I don't know if you can see it.
Oh wow, that's remarkable. Oh my goodness.
Yeah. So his foot is intact. He's happy. When he came in with a wheelchair, and his wound was getting better. Started using a walker, and then he came with a scooter. Last time, because he still has to offload, but he, drives his scooter in my office, going to the room, picking up a water bottle for me to talk to me, and he's just such a happy man compared to when I saw him the first time. So even as a physician, I gave up hope on this patient seeing that wound, how bad that wound was. But just moving forward, saying, okay, let's see what we can, he's still got his foot and he's doing well. So these are the stories that make you also want to do more, right? Because you see the reward of your work and the patients working with you to improve their health care.
So it's a good lesson, and at least try. At least try.
Try, exactly. Yeah.
If it's not going to make matters worse.
And they deserve that. These patients deserve at least you giving it a try. So.
Describe a case where a patient should have been diagnosed with PAD sooner but was not, and because of that, did present on deck for complex revascularization or amputation. And this is to raise awareness of the stereotypical, delays in care because patients are misdiagnosed with back issues, gout, arthritis, fibromyalgia, just old age, diabetic neuropathy, just your diabetes. And I know you described one case that could fall into that, but I'm sure you have quite a few more that would be a great lesson for patients who are out there, that if your doctor is saying, hey, you need a hip replacement, spinal fusion, you just need some antibiotics for that infection on your toe, that they say, okay, well, wait a minute, can we at least check our vascular system? Can you at least check my pulses?
Absolutely. I mean, several patients come to mind, but one particular, um, who had arthritis of the knee, was diagnosed with arthritis of the knee. And, she's had x-rays, went to physical therapy, she had knee injections, she had nerve ablation. And then finally, the pain management doctor sent the patient to me because he recently learned that I do genicular artery embolization, for this patient. And this patient was been, you know, getting all these different treatments over a couple of years, and still not improving because her symptoms were basically of ischemic rest pain and not arthritis of the knee. Um, but when she came in to see me for PAD, for genicular artery embolization, one of the questions we put in the questionnaire is, do you asking these questions more than the arthritis duplex ultrasound? And, guess what? She had occluded popliteal artery, tibial vessels. And I said, this is, arthritis is not your problem. Your problem is your vascular system. And so, sure enough, we asked her to do an angiogram. We did an angiogram, and we found the blockages. We improved her circulation, and her knee pain went away. So, but this disease, critical limb ischemia, can present in many, many different ways, and in a different way. So I think. If you go to a primary care physicians, they're so busy taking care of diabetes. How many times do they have time to ask the patient to take their shoes off and socks off and look at their feet? Not so often. And some of these patients, I think, understanding how patients can present with the life-threatening ischemia is very critical in our practice, as a physician, and also going out to the community and teaching, not teaching, but educating these other physicians, or bringing awareness to the primary care physicians that, look, if you have a patient with neuropathy, or they can't sleep at night because of cramps in their feet, these are the signs that you need to remember, and, send them our way, or, work them up first if you like, with the ultrasound or duplex, because there's a vascular component to these symptoms, and we need to rule that out. So I think bringing that while we're still learning, even as a vascular specialist, that this disease can present in so many different ways.
And it's not to say that you don't have diabetic neuropathy. It's not to say that you don't have issues with your back. It's not to say that you don't have arthritis. But what if those are not what's actually causing your current imminent, you know, issues, your symptoms right now. That's really what matters.
Exactly. I mean, if the patient's not responding to the therapy that you're, treating the diagnosis, then I think we need to think differently and say, hey, there might be something else.
So share a story of a patient who impressed you with their effort to improve their PAD prognosis through their own strength, their own perseverance in partnership with you and really being the best partner in their care. We had Dr. Vincent Rowe, who's over at UCLA, that shared the story of a patient recently who, and she discovered the art of grounding or earthing, and she wasn't diabetic, so her feet weren't at high risk right at that point. So she was able to find safe places no matter what to do this. She even got grounding mats and grounding sheets, and lo and behold, there's no clinical evidence, but a year later she still has her legs.
So I have a very interesting story on a patient that I've treated. So this patient was a smoker. He had a wound on his toe. He's been followed up with wound care physician and for vascular evaluation. Now, this patient came to me to see me in the clinic, and he was a chronic smoker, smoked for many years, and I could just smell the cigarette on his when he walked into the office. So I'm like, okay, this is going to be an interesting conversation. So he came to his insurance was, which we did not participate. But since he was referred to me by a wound doctor who we have a very good relationship with, I'm like, I see his patients, no matter what, and we figure things out. So he came to me, I talked to him, and he had a wound that was going on for about 6 months now. He's had an angiogram in the past. In spite of that, the wound wasn't healing, and he was smoking, pack a day. So I sat down with him and I told him, look, if you continue to smoke, you will lose your leg. Um, you know, there's no ifs or buts about it. You will lose your leg. If there is ever a time in your life that you want to stop smoking, today is the day. You know, um, and I told him, look, I can help you as far as a vascular point of view, getting your circulation open, even though you're not part of the insurance that we carry, but I'm willing to do that from my side. I will help you get your circulation open, but you need to work with me to stop smoking. And I think that impacted him a lot. Like, I'm willing to go out and do this procedure for him, even though, we're not credentialed in his insurance. So then he went and said, okay, let me think about this. So he goes home for about a week, 2 weeks, and I'd give him a follow-up appointment in 2 weeks because I didn't want to wait any longer. I said, whatever you decide, you need to decide soon. He comes back in 2 weeks and he said, Doc, since the time I left your office. So I said, okay, you did your part. Now I got to do my part. So let's go and open this, circulation in your leg so you can save your leg. So I talked to the industry again. They were willing to help out, and we put him on the schedule on Tuesday. We did an angiogram, put a stent and everything that he needed, and he's got his leg intact. And then he came back for follow-up. I said, what really drive you to stop smoking? You smoked all your life. He's like, one thing that I started telling myself is that every time I take a cigarette out of the package, I told myself, is this want to lose my leg, or do I want to smoke a cigarette? And that's what helped him to quit. And he said, I tell my mind every time that I have an urge for a cigarette, do I keep my leg or do I smoke? Do I keep my leg or do I smoke? So, and that was a very motivating story for me. That I think we have to get in the patient's mindset to have these conversations, because otherwise any other patient, I would have said the same thing, it had no impact on them, but this patient had the impact. So I think it has to work together. It has to be the right place, right time, and the right effort from both parties, to do this. So.
Oh, that's such an inspirational story. Patients don't realize that the cigarettes actually they lead to your arteries spasming. We had a patient that was over in England, and she was in what I call cigarette induced CLI because her vessels, it turns out, were just spasming, and that was leading to this wound that wasn't healing. And the moment she stopped smoking, she was getting sleep at night, and then her lo and behold, her wound started healing, and she was no longer in critical limb-threatening ischemia. It was amazing to me. I don't know if that would be classified more as Berger's disease, which has some of this similar, and it's driven by cigarettes. I was blown away. Being classified as CLI, they were ready to do an aortobifemoral bypass on her, major procedure on her, and within a couple weeks, she's walking, she's doing great.
No,
Completely
absolutely.
blown away.
No, I
The
think
power
spasm
of
is
putting.
very absolutely. Spasm plays a major role when they're smoking. And I also tell the patients, because you stop smoking and I do a vascular procedure on you, does that mean you can start smoking again? Because whatever work I've done to open up the circulation, got to go back in again, So, and other thing is also, I think their nutritional status improves somewhere because now they're not smoking. They can taste the food. Taste buds are not all burned out now. They're becoming alive. They tend to taste food better now. They tend to eat healthier. There's many benefits, not just vascular, but overall health.
So you shared your best smoking cessation speech. I'd love to hear, pretend I'm your patient. I'm not walking. Share your best, and it could be analogies you've developed or why walking works, how it means. I'm a patient. I just want procedures and pills. Just give me the quick solution.
Yeah. So walking, I think we have to determine, if the patient is a claudicant or if it's rest pain, right? Or with the wound, because their walking situation, the type of walking they need to do or exercise they need to do is going to be different. If you have a patient who's a claudicant, I tell them, pretend you're going on a freeway and four lanes are closed, and you only have, the plaque is narrowing your circulation. So all that blood has to go through really slows your blood flow down to where it needs to go. So if you don't do anything about it, your blood is going to flow very slowly. But if you start freeway, what happens is people who are motivated to go where they want to go, they get off the freeway, go on the side streets, and they get back on the freeway further down, you know. So if you're really motivated and you want to improve yourself, then you have to create these side streets, get the blood flow back beyond the blockage. And only way to do that is for you to exercise. You need to walk and exercise to build these collaterals. And if you're so motivated, you can build these collaterals so big enough that you don't need the freeway anymore. These collaterals, that's the analogy I use with patients with claudications. When it comes to patients with rest pain and wounds, now these patients have been told that you cannot walk, you have to offload, because of the wound. So these patients, I've come up, just talking to different patients. I mean, these patients are teaching me how to practice medicine because they find things that work for them and then they share with me, right? So I had patients say, I do this when I'm sitting down watching TV. I'm like, oh, that's really great. That makes sense to me. So one of the things that the patient that came to me told me is like, when I'm sitting and watching TV, I just, do these flexion and extension exercises on my ankle, where I'm pressing on a gas pedal and then bringing my foot back all the way back up until I feel the tightness in my calf muscle. And I do that. Like, that's wonderful. It really works great for these patients. And I've had patients who do 100 times an hour because it really helps them feel better, gets their strength in their legs. So when they're walking, their balance is better and so forth. So these are all the things that I've learned from talking to different patients. My practice is, I don't have a nurse practitioner or a PA, so I follow up with my own patients. So it's a close, gives me a lot of feedback of what I've
Mhm.
done and what response these patients have got. and I think that's a part of my practice that's helped me learn these things.
Of our patients who is a pathologist, PhD in pathology, and he's also he had an aortic dissection at one point, fully stented, blocked groin to toe, and he is competing at a world's level in triathlons. And one of his secrets to success in continuing to do is doing, while he's sitting down. And one of them was a modify, you were talking about, he's almost like, maybe like a sea urchin, where you're just like this and just bringing your toes out, spreading them if you can, and then coming forward and then just making it in a fluid motion, which I thought was so for people who have all their toes, they can get those. You can either use your fingers and you can try and do this, then you bring your in and out, spread them, bring them together. And you can get those toe dividers that you would get at and you can even use those. And then the towel. So spreading your toes, picking up the towel, not picking up a marble because he doesn't believe in bringing your toes together. You want to keep them spread and then pick up the towel and drop the towel and pick up the towel and drop the towel. And that's if you don't have a wound that's going to be affected, but just a couple of the exercises that they suggested. And we have Doug who's chiming in here, Douglas who's chiming in here, that he does calf raises when standing. And that's not right. Aside from walking, I mean, exercises while is really helpful. Seems to make
their toes and feet, the better it is. I have patients ask me, say, I have this bicycle thing that I use. I said, yeah, use that. But, the only thing is that you can't carry that with you everywhere. But these exercises you can do anywhere. Like if you're waiting in a doctor's office for your appointment, you can start doing this stuff, or sitting in the car, for walking, or watching TV or whatever it may be. You can do these exercises anywhere at any time,
Yep. So our final question that we want to ask you is, it was driven by the patients. It's not about, mocking patients, making fun of them or anything. They just wanted to know what mistakes that patients make that they could learn from. And we've had quite a variety of serious ones versus ones that could be considered a little humorous. But a moment with a patient that still has you shaking your head, something that patients can learn from, mistakes that they may make and they can learn from. It can be, I can't believe a patient said that, or I can't believe a patient did that, but they did. We had Dr. David Armstrong, who's with USC Keck School of Medicine, who shared the other day that a patient who had diabetic neuropathy just couldn't feel his foot, ended up with a wound on his foot, and he was resting, and the dog came over and ate his toe.
Oh boy.
He didn't have the foot covered. And you'd think that would just happen the first time, but then it happened again. It's okay, I think we need to fix this problem. Keep your
Absolutely.
feet covered, keep them away from the dog. I mean, you would think, but not everyone knows that. You wouldn't think that the dog would come over and
Right.
eat your toes. And the other one is cats. Keep the cats away from any wound as well. Don't let them lick your wounds.
Exactly. I want to maybe share a story about not a patient, during the consultation. This patient was in severe ischemic rest pain. They couldn't sleep at night without having their, leg hanging off the bed and sleeping that way. But the family member, sometimes the family members are taking these patients to all their appointments, trying to, is going on. And after some times, I feel maybe they've given up hope, on these patients or the family member, or they don't understand the pathology and thinking, how bad can this pain be? We're giving them the narcotics, we're giving them all this, but they still keep complaining. The patient keeps complaining. And I have a patient who family member was there with the appointment and just not really ready to understand by the situation where this patient was in severe ischemic rest pain. They were like, okay, it's there. So it occurred to me at that time that I need to get the family on board for this patient's treatment. And one of the, have you ever had a blood work done? Have you ever had blood drawn? Tourniquet they put on your arm to draw the blood. Imagine if I left that tourniquet on you all day long, 24 hours a day, what would happen? She said, I would be in a lot of pain. I said, that's what, your father's going through, is having that tourniquet on throughout his day and night, pain that they're feeling. And I think that really changed our mindset about, buying into, that he really needs, treatment and attention, and there something's to be done, for him, or taking them for appointments. So I just want to share that with you. I think that I thought was a good example to tell patients' family when they don't realize sometimes how bad pain, ischemic pain, can be for these
Yeah.
patients.
I think that's so important. And I love that you take the time for this. It's just another example of why I'm so excited to present our P.A.D. Humanitarian of the Year award to you, Dr. Nick Patel of AVA Vascular, Murietta, California. Thank you from the bottom of my heart for all you do above and beyond the call of duty, the hope and the love that they need to thrive in this very tough journey that is called P.A.D.
Thank you for this wonderful award. It means a lot to me. Thank you so much.